I'll talk a little bit on cryophysics basics, clinical applications, something about focal applications of cryo, and larger usage of cryo, which is in pulmonary vein isolation. If you look at cryo lesions are formed by ice formation and reheating, that's thawing, which ultimately leads to a coagulation, necrosis, and apoptosis. When you reach sub-minus temperatures, you tend to create ice formation. When you reheat, you ultimately end up in creating a coagulation, necrosis, and apoptosis. So these are two ways we create lesions. One is by radiofrequency ablation, where you create a lesion by heating the tissue. In cryo, you create a colder spot just close to the catheter and create a lesion. So when you create a hypothermia, you have a phase of reversible injury. When you create changes in the ion pumps, which lose their transport capabilities, that ultimately leads in depolarization rate decrease, action potential amplitude changes, and duration changes. There are changes in conduction rate, and electrical conduction slows down and eventually stops. Ultimately, there forms a ice, both extracellularly and intracellularly. Both of them will cause a direct cell death. So, the mechanism of tissue injury in cryo, you have an immediate tissue injury by cooling and deep tissue injury by freezing, which ultimately forms a hypothermia, ice formation, both intra and extracellular. And when you reheat, that's thaw the tissue again, it causes further damage to the tissue. You can also have a delayed tissue injury post-procedure in the form of necrosis and apoptosis. The one thing which is, you can call it unique about cryo energy is it causes a injury with the preservation of extracellular matrix. One thing again which is unique about cryo is it causes a cryo adhesion, so that improves the catheter contact and stability. It also, because it does not damage the extracellular matrix much, it reduces the risk of thrombus formation, and it usually produces a well demarcated lesions. The primary application of cryo remains in pulmonary vein isolation, but still there are applications of cryo in focal ablations also. In difficult AV nodal re-entries, when you have a very narrow Cox triangle where you are worried about AV blocks, and anteroseptal pathways very close to conduction system, paresthesia and atrial tachycardias, when you have a very difficult pathways, the concept of cryo adhesion may help. You can take the catheter to the difficult location. The cryo adhesion will make the catheter to catch to that location and will not move. And pediatric arrhythmia is another area where cryo may have a role. When you do a cryoablation, AV nodal re-entry ablation with cryo, you tend to do in a different area ablation, where cryo areas are usually little superior, and you tend to get a larger A waves than what you get in radiofrequency ablations. These are the focal application catheters which are available with Medtronic right now. The freezer family of catheters which are useful in focal ablation of arrhythmia. So when you are looking at focal cryoablation, these are the advantages. The cryo lesion expands with the leading hypothermic zone. That creates lesser injury to the closer tissues, and cryo adhesion maintains the position of the catheter tip. That makes your catheter much stabler, and again cryo adhesion again prevents accidental dislodgement of your catheter. That may be very much helpful when you are ablating a very narrow Cox triangle or a pathways very close to the AV conduction system. That's the reason cryo seems to be safer. If you look at meta-analysis, the patients requiring pacemaker with cryo is nearly zero in larger studies which are done on cryo. While radiofrequency ablation, we know we remain careful, we can reduce need for pacemaker less than 1%. If you look at long-term recurrence rate, as the procedure is much safer and you tend to remain little superficial, your cryo recurrence rates are higher. You have close to 10%, 7 to 10% rate of recurrence with cryoablation of AV nodal re-entry. We know with radiofrequency ablation, which is much lesser with less than 3-4%. The biggest advantage of cryo in AV nodal ablation remains risk of AV block comes down dramatically. if you see, there are no recorded case of persistent AV block recorded during these studies. Both the studies, they have not recorded any of the persistent AV block which required a pacemaker. So acute success rates were pretty good, and long-term recurrence were less than 7% in most of the studies. The biggest advantage remained absence of AV block requiring a permanent pacemaker. So that's for focal ablation. The primary application of cryo is in the region of pulmonary vein isolation. Right now, we know the class 1 indication for proximal AF remains refractory or drug intolerant atrial fibrillation, where you can consider a ablation of this arrhythmia. So HRS clearly says pulmonary vein isolation is the cornerstone of AF ablation procedures, and electrical isolation is recommended during ablation of all AF ablation procedures. So we have now growing body of evidence that whatever the lines we put other than pulmonary vein isolation, there are not much of a data to support on long-term success of keeping these patients in sinus rhythm. Regarding pulmonary vein isolation, we have two techniques right now available. One is point-to-point ablation with a radiofrequency, and second one is a cryoablation with a cryoablation balloon. So this is how the cryoablation works. We have a cryo console, the aortic front catheter, which has 23 and 28 millimeter balloon, and you have a unidirectional 12 French sheath. Now the Medtronic is in the way of launching a bidirectional sheath soon, and you have an achieved family of mapping catheters. These are the catheters which map the pulmonary vein potentials. So when you do a cryoablation, usually it's done with N2O. It vaporizes and absorbs the heat from the adjacent tissue, that by cooling the tissue. So aortic front catheter of Medtronic is made with PVA in mind. The cryoablation is an anatomical approach for PVA. It creates a contiguous homogeneous lesions surrounding the pulmonary vein. Using a safe cryo energy, cryo removes heat from the tissue for more durable PVA. The biggest advantage, as I already told you, the cryo balloon preserves the extracellular matrix. So I will show one of my case which was done recently. The 58-year-old doctor who had an ablation for a typical flutter some 5 years back had a recurrent episodes of proximal AF with pre-syncope. Holter showed tachybrady syndrome with the longest AF of more than 24 hours. Patient was highly symptomatic with AF. So we decided to go for a cryo for this patient. I usually put a 3D mapping system for most of my patients and do a pre-op CT for all my patients to merge LA anatomy into 3D map. And during patient was in sinus rhythm when we were ablating. So I usually pace from CS, look at the pulmonary vein potentials, and then start freezing. I'll just show one vein which we did. All 4 veins have been done. I will just for an example show this vein. You can clearly see in the achieved mapping catheter, there is spiky pulmonary vein potentials which are clearly seen. So when we started freezing, we could clearly see that I think it was in around 20-25 seconds of freeze with a temperature touching around -30. We could see complete isolation of pulmonary vein with absence of pulmonary vein potentials during freezing. This was done for all the 4 pulmonary veins. The total procedure time was somewhere between 40 to 45 minutes after transeptals. Both entry and exit blocks were confirmed. And one big advantage with cryo in long term is the pulmonary vein isolation is really good and long lasting. This was a 3D map of this particular patient where we did a pre-mapping. You can see voltages spread across LA into the pulmonary veins. This is a post-freezing map. You can see a complete isolation of all 4 pulmonary veins. One good thing we observe with cryo is a good VACA you get. Good wide antral ablations are possible with cryo. The reason being the balloon is 28 millimeter. When you put this 28 millimeter balloon into the pulmonary veins, you tend to create a lesions which is larger. You can have around 73% of posterior wall ablated during PVIs with cryoballoon ablation. We know very well one of the common area which is pro-arrhythmic in most of the patients with proximal AF is the posterior wall of LA. So along with pulmonary vein isolation, you tend to get close to 73% ablation of posterior wall of LA also. This is the advantage of cryo again. As a durable and transmural lesions, we know which is the key for a pulmonary vein isolation. With cryo, you tend to get the lesions which are much more durable. And the other thing is, as far as the complication is concerned, we know the efficacy is non-inferior to radiofrequency ablation, with the complication rates much lesser than the radiofrequency ablation. That's the reason you could see the single procedure freedom from AF across Europe. You could see the success rate in the range of more than 80%. And another advantage you should see is compared to radiofrequency ablation, you can see the radiofrequency ablation, it's very much operator dependent and experience dependent. When it is done by an experienced operator who is performing more than 500 procedures in a year, the success rates are extremely good. While at the same time, if you look at the AF done by an operator by radiofrequency less than 100 procedures per year, the success rates vary very much. While look at cryoablation, the difference is much lesser. So when compared to radiofrequency, outcomes are less operator dependent with cryoablation. This is one big advantage. When you have a centers which does not do a lot of cases, you tend to get good success rate even with the operators with a lesser experience. So with this, I'll close my discussion. If there are any more questions, I'll be happy to answer. Thank you.